Welcome to meeting number 4 of the House Budget Review Subcommittee on Health and Family Services. The meeting materials were put online earlier this week and made available for downloading. At this time, we'll have the Secretary call the roll.
Representative Bowling. Representative Fleming.
Here.
Representative Raymond.
Here.
Representative Wilner.
Here.
Representative Petrie. Representative Reed. Representative Heverin. Representative Moser. Chair Bentley.
Yes. We have a quorum then, 3. Next, we have approval of the minutes for the February 22nd meeting. Do I hear a motion? Second, please.
Second.
All in favor say aye. Opposed, like sign. Minutes pass. I want to preface this meeting. I'm supposed to be in 3 committee meetings at the same time. And like Mr. Bowling, I know he's in 3 too. So I'll be up and out. So just be patient with us today. It's that time of year. First up this morning, and please keep your presentations brief today. Common sense tells you we're all pretty thin out. I'm supposed to be at 3 at one time. First of all, this morning we have representatives from the Department for Public Health to give us an overview of the Kentucky Prescription Assistance Program. We call that KPAP or KAPA. Would you please identify yourselves for the record? And members, hold your questions until the presentation is done, please.
Good morning, everyone. Thank you, Chair, and thanks to the committee members for having us here today. I'm Elizabeth Good from the Department for Public Health.
My name is Jennifer Turibio-Nas. I'm the Program Administrator for KPAP.
Thank you again for this opportunity to speak with you today about the Kentucky Prescription Assistance Program, or KPAP. KPAP has a mission that's really twofold. Foremost, we consolidate all the National Prescription Assistance Programs, or PAPs, into one location to make all hundreds and hundreds of programs more accessible to Kentuckians who need assistance accessing free or reduced cost medications. But secondly, our mission is to also, when we work with these folks, to assist them in making connections locally to assist them with other needs in their daily lives that they may have, such as like housing and access to food. So prescription assistance programs are typically provided by national drug manufacturers, discount medication programs, and pharmacies. And each of these programs has a very distinct application process that's complex for every single drug that they offer. And what our program does is consolidate that application into one application, so that if a person needs access to, say, 10 medications, they only have to apply one time. Most of the criteria for applying for assistance is based on income levels and insurance coverage, but there are varying types of other qualifications that they may consider. And eligibility for KPAP really depends on the needs of that individual person. Individuals with different income levels is a priority, but also we work with a lot of people who may have an inability to access medication because they're in the Medicare donut hole, or they have insurance, but the medication that they have a great need for is not covered by their health insurance. If a person is not eligible for a drug that they need, we also seek out other opportunities to provide copay assistance or even other available programs that may help them. So this work is primarily carried out by about 500 volunteer advocates that we train and support throughout the state. And they work one-on-one with individuals who reach out to us and need assistance. They meet with these people, interview them, fill out all of the information that is required by our database, and submit applications on their behalf. It's important to note that if they receive a denial for accessing a medication, we do go back and try to work to reevaluate and submit additional information. And then also importantly, it's not a one-time thing. We provide refills and follow-ups with those individuals to ensure they have ongoing access to their needed medications. So you can already tell that this is more than just a prescription assistance program. We are an important network of providers throughout the state. We have a small staff that's made up of people who train and support all of our advocates. We have community consultants that are located throughout the state and train and support those advocates that are located at the local levels. We have a hotline, so a 1-800 number that we answer and assist folks with, and then we refer them to advocates in their communities. Our volunteers, besides helping those people fill out their applications for prescription assistance, also find out that these people a lot of times need help with housing, accessing food, other resources, and they make those connections for them. Our KPAP outcomes are just amazing. We improve access to free and reduced cost medications, but we also improve medication compliance, which thereby reduces visits to the emergency room and long hospitalizations. We build social networks and relationships. It empowers Kentuckians by eliminating their healthcare barriers, and overall, we improve the way of life for so many Kentuckians. I did want to share with you a top, basically 20 list of our medications that are most highly used in this program. In fact, when we look at just the top 10, 9 of the top 10 are related to diabetes. So there you see the top 10 diabetes-related drugs, and then the other top 10 prescriptions that we assist with. Now, importantly, we run on a shoestring. Our budget is $667,000 a year. About half of that is for our personnel, and just a third supports the software that we use to make all these important connections. So it's really a small budget with a mighty impact. And when I say mighty impact, in 2022, we saved Kentuckians $46 million in prescription costs. We served 4,808 individual Kentuckians, and we helped someone in every single county in Kentucky. And when you look at this impact, since 2008, when our program began, we've served 95,000 Kentuckians with a cost of almost $1 billion, $898,000 in medication value to Kentuckians. So a huge, huge impact since 2008. We are working to make ourselves more accessible. This is the secret we don't want to keep. So we definitely need your help sharing the word with our budget. We don't spend a lot on advertising, but we do work on making our webpage more accessible, updating our promotional materials, and working closely with advocates and leaders all across the state. And then we're also working to optimize the ability to access us through search engines such as like Google. Here's our team here, and these are the folks that support those 500 advocates and also the thousands of people that we are able to help here in Kentucky. Thanks again so much for having us today.
Thank you for your presentation. Any questions from the members? Sure. Those will introduce some guests while we're trying to think of a question.
Thank you for the presentation.
Representative Ring.
I want to introduce students who are here today from EKU's Global Leaders Unite program. wave at us. It's a group of student leaders that are part of different multicultural groups, such as Divine Nine organizations, BSU, and LSA. They're here today visiting to learn about advocacy and attend the Crown Act rally this afternoon, and their advisor is my friend Martina Jackson. Thank you all for coming.
Welcome. Director Good, I had a question, of course. Sometimes people file bills to try to help with the cost of drugs. Sometimes those things don't match up with your program, right?
Yes, sir. It definitely depends on the language in the legislation.
Okay. I don't know if you saw it this morning, but Eli Lilly reduced the cost of their insulin by 75% across the board. That's a big victory
Absolutely.
for all of us, even the assembly, because a lot of us have been working on that for several years. 75%. I've been to Lilly before, and it's interesting that they store insulin and rotate it out of a hidden place in case we ever have a national disaster and we come out of it. So they rotate it in and out. It's a very responsible company on that part. So if you're in Indianapolis, visit them. Okay, thank you very much for your presentation. And CAPA needs to get information out, and this is one way of doing it.
Thank you.
Thank you all. Okay, Medicaid reimbursement for pediatric behavioral health services. We have people there for presenting. Thank you to the presenters, and our next presentation is from the Children's Alliance, KVC Behavioral Health, and RAMEY-ESTEP to discuss Medicaid reimbursement for pediatric behavioral health services. So presenters, please identify yourselves for the record, and everybody's up there.
Morning, Chair
Okay,
Bentley.
members, hold your question until the presentation's over.
Good morning, Chair Bentley and Subcommittee. This is Michelle Sanborn with the Children's Alliance.
Oh, thanks. I am Jared Dungan with KVC Behavioral Healthcare Kentucky.
Hi, Kelly McCormick, Chief Treatment Officer with RAMEY-ESTEP Regroup.
Okay. Michelle, why don't you start?
I will start, and I just wanted to put some information in about the Children's Alliance. Most of you know who we are, but you're more familiar with us caring for about half of the children in our out-of-home care system. But today we're here to talk about those members that provide behavioral health services, which is a true prevention before those kids come to the knowledge of DCBS. We're talking about Medicaid, behavioral health services organization, and multi-specialty groups. And these are behavioral health services that work out in our communities that serve thousands of children and families. They predominantly work with those that are very high needs and in the homes, in the schools, out in our communities. BHSOs and BHMSGs have consistently been underfunded for years. The Kentucky Medicaid program, if you look at their regulations, only reimburses 75% of the Medicare rate, and that's for doctors. It goes down and below for that. We're consistently lower than our surrounding states, in some cases as much as 35%. And I can say West Virginia, which is bordering some of these folks, they pay $42 an hour more for an hour of therapy than Kentucky does for our BHSO services. That's a significant amount, and obviously I know folks that are on that border are losing our staffs across the border. So the demand for behavioral health is increasing. We've got more people in our Medicaid enrollment and our Medicaid system. Also, the U.S. Surgeon General has reported that we're in a mental health crisis for our youth, and you can see some of the data. Anxiety, depression, everything it's going up, and it's going up fast. And when you see these, you're like, okay, yeah, that's the United States. What's happening in Kentucky? These are some numbers taken from a report that is done in our Kentucky schools in 127 districts across our state. These are the numbers from 6th grade, 8th grade, 10th grade, and 12th grade, and you can see this over time where we are. So this is how many kids, 25% are reporting serious psychological distress in the last 30 days. And you can see how that's gone up. Feeling nervous, going up. Suicide plans, going up. While all the need is going up, our behavioral health therapists are going down. We received some numbers from our Medicaid program that said our BHSOs had 309 licensed behavioral therapists last year, and this year we're at 236. And you're thinking, well, that's not very many licensed therapists. That's not very many therapists to care for thousands of kids. Most of these programs have licensed therapists to provide supervision, and then there's the associate level that's provided underneath those licensed therapists. And so not only are we losing the licensed folks, and these are master's level with 2 to 3 years experience in their field, we're losing the associate level, which is just a master's level, and they're working toward that license. So they're maybe just recently out of school, but they're leaving, and folks are saying, well, maybe they're going to the hospitals or schools or to the MCOs, places that can pay more, and we've just got a shortage of therapists. The problem is they're leaving to go outside of our field. So when the demand is going up, unfortunately, we're seeing our therapists leave in droves. The Children's Alliance did a survey last year of our members. So this is a small portion of those BHSOs and BHMSGs. But the average salary for a master's level was $48,000, and for our masters with a license was $52,000. And you can see our turnover rates. But I just read the report where DJJ has hired 81 new DJJ workers, which is great. But guess what? We've raised their salary to $50,000. So those folks who don't have a master's degree are making more than and close to our masters with 2 to 3 years experience. So it's just not sustainable. Here's some data again from that survey of our members that provide BHSO services and where they are. The waiting list, 42 days actually is really short today. If I ask folks today, it's at least a month and a half. And I would say if I'm having a mental health crisis or my child's having a mental health crisis and you say, well, come and see me in a month and a half, there's going to be issues, right? We're probably going to end up in the ER or potentially worse, right? So we need to be working to make sure that we're seeing these folks in a short amount of time. And so, but many of my agencies have waiting lists. You can see the losses these agencies are incurring, and so they're coming to me and saying it's just not sustainable. Many of them, their boards are talking about just eliminating these programs. Along with the demand going up and the supply going down, our administrative services are increasing. So when you see Senate Bill 29, that's really where these talking points really fit. We get so much administrative burden placed on these behavioral health entities. And from 6 different MCOs, and it's really, again, it's increase our administrative services and decreasing the time that we can provide treatment. So what we're asking is that the General Assembly require that Kentucky Medicaid behavioral health and substance abuse disorder folks, the BHSOs and the BHMSGs, be paid 100% of Medicare. And what we know about Medicare rates is that they're about 80% of costs. So when you cut 25% off of that and that's where we start at our highest, again, it's just not a sustainable system. We have to have some kind of methodology where we know, and it goes up and down based on our economy and the market. And that's what Medicare does. They do those cost reports and they have a system to define and understand where these services need to be. But yet we're just cutting 25% off kind of randomly. There's really no thought about that. It's just a 25% cut. And what we would say is we need to go ahead and reimburse the full 100% of Medicare when we serve these children. So I would say if my parents can get this service, Why couldn't the children and families that we serve? And you can see the drawdown. The state investment's about $20 million, and the federal drawdown is about $46 million. So the reason why I'm here, because I know it's not a budget session, but I would say we're in a really critical time in a crisis, because I hear from my members that they're closing. And for me, I've worked really, really hard with this body to focus on prevention. And we've really invested in prevention, and it's working. Our numbers in out-of-home care are going down. And we've invested in programs like K-STEP and what's the other? Family preservation. But those are kids that come to us after they're referred or after they become known to DCBS. The kids that our BHSOs serve and our MSGs serve, those are children that have not come into our knowledge or care, right? There's not referrals there yet. But yet they're serving them in their communities with their families and preventing them from going into higher levels of care. Psychiatric hospitals at $500 to no telling a day. They're keeping them out of incarceration, which we're hearing the DJJ costs about $500 a day to incarcerate kids. Foster care, that's at least $150 a day on average. Plus for those children. And so it really does save our state, and it's better for kids and families to serve them in our communities. So I'm concerned that we're losing an infrastructure and we're not sustaining a program that we know is effective. I've shared some success stories with you. Obviously, I'm not going to go through those, but just wanted to just share those. You can read those. But I wanted to bring my colleagues, Jared and Kelly, here to talk a little bit about their programs and why they're coming to me and why it's important that we come and share this information with you today.
Okay, Jared, you got about 3 to 5 minutes.
Okay, thank you. So I'm Jared Dungan, Vice President of Operations with KVC Behavioral Health Care. KVC has over 20 years of experience with community-based, child-targeted, and family-focused behavioral health services. We started as an Impact Plus provider many years ago until it was discontinued in 2014 when the Behavioral Health Network opened up. For those that don't know, Impact Plus was a Medicaid carve-out focused specifically on treating children in their communities who were at risk of higher levels of care, where the children were exhibiting problems in the home, school, and community settings. So lots of complex cases there, and we continue to do that work after the Behavioral Health Network opened. Currently, we're also one of the largest family preservation and K-STEP providers in the state. Those programs also focus on in-home work with families who are experiencing very complex needs and mental health issues, where we deliver in-home evidence-based clinical practices similar to what we do in the behavioral health world. And in fact, for KVC, we took our approach from our behavioral health work into our child welfare work. As Michelle mentioned, we are in a mental health pandemic for youth. Acuity is higher at all levels of care. Agencies like ours play a critical role in the system of care. For us, in fiscal year 22, for instance, we served 488 individuals with psychotherapy, and 65% of them had either PTSD or another trauma-related diagnosis. 81% of those had a history of physical abuse, sexual abuse, neglect, or verbal abuse, emotional injury. The vast majority of these youth are pre-system involved, as Michelle says. So we know this work is a preventative work, and it's very important. We receive referrals from over 100 unique referral sources. 47% of those come from schools directly, who obviously schools have many more mental health practitioners today than they did just a few years ago. But these are referrals we're getting because they are too complex to be worked in the schools. 11% of our referrals come directly from psychiatric hospitals. While all this work is wonderful, there's a major problem. As the need for this level of care is increasing, based on the stats Michelle shared, the sustainability of services is rapidly decreasing. Since fiscal year 2019, our agency has averaged a 17.4% financial loss for the last 4 years. One caveat is that I adjusted fiscal year 21 because we did receive some CARES Act due to the COVID relief, and so we adjusted that revenue just to look at operational bottom line itself. Meanwhile, the world has the need for master's level therapists has greatly increased. Because of our losses, however, we couldn't increase salaries enough to compete. And some stats in fiscal year 2019, we served 848 clients in that year and had 34 therapists. As of fiscal year 22, we served 488 clients and we're down to 10 therapists. Today we have 7 therapists. We cannot afford to invest in this critical network because of the losses, and the thing that we want to do most is invest, grow our programs back to what they were, and continue the prevention services. So in order to, we also currently have 143 clients on our wait list that we can't get to. When we do get referrals, we are assigning them based on acuity, which means generally it's the highest need. We're filling our therapist caseloads with the absolute highest need and most complex. That is a major burnout risk for our therapists, and we see it every day, which is also another factor in the turnover. In short, I think it's clear we're asking for financial relief and help to support these services, and we know there'll be a long-term payoff. Thank you.
Hello. Kelly McCormick again with RAMEY-ESTEP, the Chief Treatment Officer. We are located in Ashland, Kentucky, which is in Boyd, northeastern region. They're close to Representative Bentley. Many of the things that I was going to discuss, actually, Jared has already shared, so I won't continue. Our history is very similar to KVC's in regards to the Impact Plus work and that outpatient behavioral health work. We also have been a provider for residential youth care and foster care as well. So kind of that full gamut, right? And we know that it's imperative that we continue to try to keep our kids, Kentucky's kids, out of home care. There's always going to be a place for it, right? But we know every time they come into care, every time they have to move because of a disruption, that's another trauma to a child that is just not needed. So our goal is to keep the children from moving into that. And that's why RAMEY-ESTEP originally moved into that out-of-home care, because we would see those children in out-of-home care, and we knew that we needed to do more work in the home. We needed to help the whole family and not just that child coming into out-of-home care. And this is the way that we can do that. And we've seen such great success with that through our prevention programming. And I'll share a very quick story just to kind of let this hit home. We were called into a school. We got a referral from one of our local schools. And they said, we've got this 9-year-old terrible kid, sleeping all day, not doing his homework, disrespectful, but on and on and on, all of the things and all the terrible words, right? So we get in, we start working with this family. We do in-home work, which also is it's very tough to do in-home work with the rates that we have, because we're just not sitting behind a desk seeing people. We're meeting them where they're at, which means we do less services in a day, but they're more quality, they're more meaningful because we're actually involving them in their place where they are. So we start working with this family in the home and realize it's just chaotic in this child's home, right? There's people in and out of the house all the time. So he's not feeling safe to sleep. He can't do his homework because he shares a bedroom with 3 other children. So when we got in there and really started working with him and talked with the school, we were able to turn this whole child's experience and his education and home life around. If we weren't doing that work, this child would have he would have been referred to DCBS, he would have went to foster care, he would have ended up in residential, which is just so much more expensive. But also, what does that do for him and his family, right? And so we want to really just continue to ask that you guys help us fund those front-end services so that we can help the children and keep them out of out of the DCBS world and keep them home and make healthy families. The best thing we can do for families or for children is to have healthy families. So we have to be able to work with that whole unit.
And I will say, this is Michelle Sanborn again. I noticed on the agenda that it says pediatric. Obviously, we are focused on children, but the rate increase would include adults, and that's what we do. We work with the children and their families to make a holistic approach. And so just wanted to make sure we clarified that rate would also include adult services as well.
That's the reason I have, because I realized that your payment wasn't keeping up with the demand. Naturally, no one y'all come in, so in Frankfurt you start now and you get to see results 2 years later. So I understand where you're coming from, and I've talked to Michelle about this many times. Right now we have a question by Representative Wilner.
Thank you, Mr. Chairman, and thank you for bringing in this presentation. And I think you guys are largely preaching to the choir here, and we understand the importance of prevention. We understand that the mental health needs of our kids have never been greater. We're seeing it, in behavior in schools. To your story, we're seeing it everywhere, and trying to find solutions by kind of harshing down on kids. Let's make juvenile justice harsher. Let's make schools less tolerant. And it's the wrong approach. And certainly getting our therapists paid is to keep them is the bare minimum of what we should be doing. So, please know that you have champions on this committee who are fighting for that. And then, Jared, I wanted to ask you specifically, could I get a copy of your testimony?
Sure. I'd be happy to.
I'll take the paper copy from you
I
today.
I can hand it right
or
over.
if you could email
Yeah.
that to us, that would be
Okay,
that would be
wonderful.
great. Thank you for being here, and
Absolutely,
thank you again,
thank you.
Mr. Chairman.
Send it to staff and we'll get it to everybody on the committee.
Okay.
Okay? Representative Raymond, did you have a question? There's only three of us here, so I'm asking you personally. I have a question. How many master level therapists are there in the state of Kentucky?
So I don't know in the state of Kentucky. In our BHSOs, there's 236 licensed therapists, and that's the only data that I can have. So I don't know the whole associate level, which would be a master's level. I don't have those numbers.
And Michelle, how many years does that take of post-secondary work? 5,
So-
6, 7?
No, usually two. Post-secondary to get a master's. There are some advanced programs where it's a year and a half, where they're trying to get folks through quicker, so they're out in the community. But yeah, usually two.
And then we see a minimum of 2 years after that to get fully licensed, and that's someone who's really working really fast. Very often it takes.
I think
longer.
people need to understand that. That's the reason I ask it. On triage, Jared, who does that triage for you? Your
Our-
acuity you were talking about?
Right. Our behavioral health director, that's one of her primary responsibilities. She's a licensed clinical social worker. She's got many years experience. She's able to do supervision. And as part of her work, and we also have other supervisors available to consult if the decisions are difficult. But she looks through reasons of referral, presenting problems, who the referral source is, and we don't like being in the situation of having to choose like that, who to extend services to. But unfortunately, often it comes down to where is the most risk of harm with an individual, kid or referral, and so she's making those decisions every day.
Kelly, you got anything else to add?
I was going to actually, we're located right there with Ohio and West Virginia, and like Michelle said, it's almost impossible to recruit new clinicians in our area, and I know that several other of the agencies are experiencing the same thing. We just want to be able to get those good quality licensed people in our door so that we don't have those 100 plus. It like Jared said, it breaks our heart to be able not be able to serve them, but we know that we can't just continue to pile them on to the 7 to the 10 to the 20 clinicians that we have, because then we're not providing good care to anyone. So we have to make it's a tough role to drive that balance, and just to make sure that we can take care of the kids and take care of the families that have trusted us in their moments of crisis. And so we thank you guys for being our champions, those that are. And it's
well,
very
you do
important.
have advocates in this committee, like Dr. Wilner said, Representative Wilner said, and you're always welcome to any of us here. This is your house, not ours. And problems like these need to be worked on more. Okay. Thank you for your presentation.
Thank you.
For our final presentation, we have a discussion of the Mobile Crisis Service Loan Program that was funded in House Bill 1. That idea came out of the task force for severe mental illness, which I was the chairman of part of that. And I know that I was with Pathways in Ashland when they had their, I call it bus, out, and we were in my hometown, South Shore. And so 2 men came up who had PTSD, and they said, I'd come here, but I won't go to a major city. But I'll go to a city, it's less than 1,500. So I know that Mrs. Nunley has really good data. So that's the reason we had suggested this. And then we had over $2 million put into that. So maybe I wrote the bill wrong. So we want to see more people use that. So Mrs. Clark, you can provide that overview for us for the loan program. Thank you for being here.
Good morning. Thank you, Representative Bentley, for the chance to discuss the Mobile Crisis Loan Fund. We appreciate the funding that we did receive for 988 implementation and mobile crisis service enhancement last year. It has been incredibly helpful as we've rolled out 988 as well and began to work on the mobile crisis response system across the state. So I am going to provide just a quick update, and I promise to be brief, on the Mobile Crisis Loan Fund and where we are at this point. So as you mentioned, the funding for this mechanism was actually in House Bill 604 and then funded through House Bill 1, and it became a part of KRS 210-368. So the loan fund was established specifically to provide loans to CMHCs, community mental health centers, in order to increase access to mental health services and to provide individual services to individuals who lack access to transportation and so it's a twofold. They lack access to transportation, and they live in a rural area. They're homeless, or they are disadvantaged mentally, physically, or economically. As Representative Bentley stated, $2.7 million was appropriated for fiscal year 23. $3.5 million has been appropriated for fiscal year 24 for this Mobile Crisis Loan Fund. These are a portion of the total monies that were designated for the 988 implementation and mobile crisis service expansion. So CMHCs could request up to $225,000 per fiscal year for a total of $450,000 across the 2 fiscal years for this purpose. And they could be utilized to staff mobile crisis teams, to purchase vehicles, as Representative Bentley mentioned, for use by the teams, or to equip their vehicles and their staff. They could also use them to use the funds to cover times when their services weren't covered by Medicare. I reference a situation when one of our CMHCs responded with their mobile crisis team to a site. They were on site for 4 hours. The individual ended up hitting the law enforcement officer, and so that person went to jail. That 4 hours of time was not billable and could not be recouped. So these funds could have been used to help cover those kinds of costs. Let me see, sorry. So we worked with state procurement to develop an application process. As was described, we set up the accounts and then determined the repayment process with our CMHCs. Once that process was completed, the notice of loan opportunity was issued to our CEOs and to our crisis call center directors. at each of our 14 regional CMHCs. That initial issue was on October 20th with a due date of November 10th. It was a very expedited process, so it asked very few questions. It did include a request for them to work with us to identify, basically do a needs assessment of their system as they move forward in order to determine what additional needs they had related to mobile crisis services. We did not receive any responses from the CMHC in regard to the NOLO by that deadline. So we did issue a second offering and asked for, let's see, hitting the wrong button here, going the wrong way for sure. Sorry about that. Now look at this. All right. At that time, we also requested that when we sent out the second issue, we requested that they actually confirm with us by December 2nd whether they were or were not interested in that loan fund. We did receive responses from 7 of the 14 as a result of the second offering, all of whom indicated they were not interested in receiving a loan at that time. We did not receive responses from the other 7. We have since talked with them, and again, they reiterate that they are not interested in obligating their centers for a loan at this point. They did indicate that should this be switched to a grant, they would be interested in reassessing whether it would be. I think they would be, yes, sir.
Interrupt all the time.
That's fine.
That's my job.
Yep. And I'm almost finished, so
Okay.
I think that's the key. The CMHCs have all had a very hard year. As you just heard, we too have kind of a drain of licensed folks and those working under them and being able to provide services, just being able to access. I think the idea of the vehicle that Pathways has is an incredible idea. We were actually able to utilize that during the disaster in Eastern Kentucky when Pathways helped backfill for Kentucky River. They utilized the mobile vehicle that they had. I think at this point it's really their looking at their financial stability, their financial ability to repay, and being able to use those funds for items that would not be reimbursed by Medicare at this point or Medicaid.
I'm a real supporter of this program. I know it'll work in rural Kentucky, and we're really short of care in rural Kentucky. Anyone have any questions? Dr. Wilner? Oh, Representative Wilner, sorry.
That's okay.
Representative Raymond?
Well, and I really just turned around to look at you just to acknowledge your leadership in
Absolutely.
these mobile crisis units. It's so important. But so many times we understand what's needed. We have, leadership like this saying this is what's going to help our rural communities, but then we don't step up and pay for it. And so you're right. I know the CMHCs are in a really vulnerable positions financially right now for all the same reasons we heard from the BHSOs who presented just ahead of you. And so, we need to put our money where our mouth is and really support these programs.
Right.
Representative Raymond?
Yes, I. In addition to looking at the funding model once again, I wonder if we could look at who it's open to. I wonder if school districts would have interest, and police departments would have interest, and other entities that interact a lot with our youth. Someone's nodding, so we can have conversations about that. Might it be possible?
Yes, absolutely. That's an option, and I think looking at some of the other providers in the region would also be a possibility as well in the regions, rural areas.
I think we need to get that data, but I know it'll be positive from the one Pathways had. And Ms. McCormick, did you have some comments on this too? Our Director Clark, you can sit there.
Okay. Kelly McCormick again with RAMEY-ESTEP. Yes. So this, this was unavailable to BHSOs. Like she said, just the CMHCs were available for that original money to help with this. And I think that I know that there are several BHSOs in the state that could also benefit and utilize these units. I think just a couple weeks ago, we were called to Boyd County High School. They had a student pass away. So we sent a whole team out, and there was nowhere in the school for us to meet the multitude of children, that needed our services that day. And so this would have been a perfect example of how we could have utilized that on that day. So yes, when you say, could we potentially open this up, we would love to have that opened up to other providers who may be able to provide those same services as well.
So what I'm hearing is we need to do a grant program to have people participate, and we need to include the BHSOs.
Yes, please.
Okay. Okay, any other questions? Okay, thank you to the presenters. This is our final meeting for this session, and thank you all the members for coming, and I think we covered some really good subjects. Now the next item is adjournment. Do I hear a motion? In a second. So we're adjourned.